So welcome to week 5. I mean, we are like counting down very, very quickly now. Next week will be reviews. I'm doing mine on next Thursday at 4 p.m. Of course, they're all recorded. Of course, you see how I put all the reviews in. As I get them, I just go in and edit one announcement. So it's in one place. You'll see the Kahoots there. You'll see the study guide there. Any other information I think you should have will be in that announcement. So one-stop shop instead of looking for 28 different places where things are. You guys have enough on your plate, 3 different classes and all the other stuff that you do, work, job, family, et cetera, et cetera. You don't need to be looking through 28 different announcements. So today it is respiratory and cardiac. I'm an old cardiac nurse. I opened a cardiac unit at Nicholas Children's Hospital in Miami. And probably my best love is cardiac ICU in children. So I can explain this as a garden hose. So wait for that as second part of it. And then respiratory. Remember, respiratory and respiratory distress. Children and adults are different. And I'm going to try to, between lecture and between the Kahoots, try to get you to understand what those differences are, okay? Because children are very fragile. So this week we do have a discussion question and another CJ Sims. You've all been really good if I've sent you a message. This isn't the right CJ Sims. I need this, that, and the other thing. If you submit it on time, you get it back to me before the end of the week. I will take credit for it. I'm not going to hold you against, the first time. So from now on, I hope that you can get them in correctly. So let's go to our PowerPoint. Any questions about anything? In the end, I'm going to go over the project and remind me if I have a moment of unclarity, okay? So I want to hit you at the end. So chapters 40, 42. So respiratory infections can either be upper airway or lower airway. Now, children are a little special with their upper airways because aren't children always full of mucus? They're always with their nose running. And then what happens with all that extra mucus in the upper airway? Well, it goes to those short, straight eustachian tubes up into the ears, ear infections, right? Or it drips down, it goes to the lungs and causes a big cough or causes sinusitis. That's all upper respiratory. Lower respiratory would be pneumonias. It also could be asthma, where the lung traps the air in and you can't expire it out. Most of the time, viral infections are what your upper respiratories are. They're viral. You go to the doctor's office with a child and they with big fevers. Actually, viruses have bigger fevers than bacterial, like pneumonias. But viruses are usually what they are. Now, there's something called an RSV, a respiratory syncytial virus. And you're like, oh my goodness, it's really a bad thing. Well, it's a virus. For you or me, it's a common cold. For a child, it's just they don't feel good because it's a low-grade fever, runny nose, cough, you're sneezing. You don't feel great. But an infant, all they need to do is suck, swallow, and breathe. And then you put mucus in their nasal passages. They're obligatory nose breathers. So they can't breathe, suck, and swallow and eat. And then they start their retractions, nasal flaring. And then if they get to the point where at the end of respiration, they're grunting, like, uh, after every respiration, that child is about to code on you. That's severe respiratory distress. You opened up, their onesie or whatever they're on, you would see, supraclavicular right between the clavicles, pushing really far in, and you would see their intercostal retractions. So RSV is a virus, and it's only when the kids are younger that it's a big, big thing. Now let's look at infants again. Infants Remember, they're born with mom's good antibodies and, all of her defenses, but they start to go away. We know that we're giving immunizations at 2 months, 4 months, 6 months, right? A lot of them to try to catch them up and prevent them from getting those really bad infections. Um, but between 3 to 6 months, because all the mom stuff, all of those normal viral type of illnesses she's had, and all those antibodies that she's built are going away, the infant hasn't built them yet. So you start seeing kids getting sick then. They actually say if you see an infant below 3 months who is sick, fever, it's actually a high alert chart if they walk into an ER because they shouldn't be sick yet. It's that 3 to 6 months we start to expect it. Now, toddlers and preschoolers, there's a high rate of viral infections. And the reason is they tend to get to groups of kids, whether daycare, school, preschool, whatever, and they play with toys. And what do they do with the toys? They share the toys. And what do they do with the toys? In the mouth, right? So what they do is swap spit all day long. And that's exchanging germ to germ to germ. That's why it gets higher then. And then after 5, they've had all of the swapping spit with all the other kids, all the other viral sort of illnesses. Their immune system is pretty strong now. So now it's more the bacterial type of infections that they'll start to get. Now, as I said, with upper airway, all the mucus goes to the area of least resistance, is up those straight, narrow eustachian tubes, up into the ears, and creating ear infections. Now, ear infections in children hurt. So usually you'll ask even a 2-year-old, which ear hurts? And they'll point to it or take the other hand and put it to their ear. And it's like your heart breaks for them. And they're telling you and they're whining. Priority care on an otitis media is to medicate for pain. Why not the antibiotic? Because they all need antibiotics. It's a staph infection, guaranteed. Well, an antibiotic takes 24 to 48 hours to really work, right? But they're in pain. That's your priority at this point. Now, if they have a lot of ear infections, something's going on with that, inner ear, they're going to put in tubes. Actually, I just had some put in January. I've got one ear that doesn't cooperate with me. So I've been very accustomed to it. And I realize why children are put to sleep. You can actually hear them cut your eardrum with a scalpel. They put in a little tiny suction device in there. You can hear the suctioning out the mucus, and then you can feel the tube being put in there. Is it painful? Not really, because they put numbing stuff there, but it is a lot of noise. So children wouldn't be able to tolerate that. Plus, when I get up, I'm dizzy. I have to hold on to the wall getting out of the office. As I said, eustachian tubes are really open and short, and that's why mucus likes to go there. What do you see besides the pain in the ear? Well, you may or may not have a fever. Some do, some don't. But remember, kids don't feel well. What are they going to do? They're going to stop eating, guaranteed. Now, sometimes it comes to the point, vomiting, diarrhea, abdominal pain. Sometimes with children being sick, cough, upper respiratory, you might see them with that annoying cough, nasal, secretions coming out. And then, of course, bronchi everywhere. And a lot of it's upper airway that's sounding like lower airway mucus. So in upper respiratories with ear infections, what do we want to do? Well, even ear infections are usually a lot of mucus involved in the upper airway. You just want them to breathe easier. You want them to rest. We don't want infection to go to the whole family. And if we get that fever down, guess what? Once the fever's down, they're going to eat and they're going to drink, which is what every child with a fever should do. They're losing more fluid, right? Now, infectious mononucleosis is a child who presents with a sore throat, fever, and flu-like symptoms. They also have swollen lymph nodes, neck, groin, armpits, but they do get swollen liver and spleen, and the spleen blows up like a balloon, okay? So it's a virus. Herpes, like Epstein-Barr virus. Now, these children usually go to their general practitioner, sore throat, feeling crappy. They do a strep test, they do a flu test, influenza. Everything's negative. Take a culture, it's all negative. So they say, oh, you're a virus. Go home. Tylenol, Motrin, increase fluids, rest. A couple days later, they're still just as sick. They go back, and the doctor says, well, I don't know, but let me give you antibiotics. A couple days later, they go to the ER because now they still feel horrible. It's been a week. So we get these children in, and they're complaining of that sore throat, fever for a week. They've taken antibiotics, nothing is working. We're going to suspect infectious mononucleosis. This is the kissing disease, right? So we'll do number one is CBC. What are we looking for? We want to look for elevated white counts. Is it a bacterial infection or viral, right? If it's a normal white count, it's a virus infection. Then we're going to be doing a mono spot test. And if it comes back positive, we'll be sending the child home with very, very strict instructions. Well, it's viral, so it's all symptomatic. Extra fluids, ibuprofen, acetaminophen, alternating every 3 hours for that fever. And that spleen is swollen, right? It's a balloon that you could punch the abdomen and pop. We're going to tell them avoid contact sports. And if you have other children at home that like to wrestle around on the floor, no wrestling until they're cleared by their pediatrician, usually about 3 weeks. Now, why do I go into that? I had a little boy who was 9 years old who came into the ER with his father. All the symptoms I just said, he was mono positive. Now, the physician was a great physician, told the child, the treatment and no contact sports, protect that abdomen. The spleen was enlarged and we didn't want it to be exploded. 1 week later, and I told the father this on the same thing, just to be sure. 1 week later, I am the primary trauma nurse on duty. We get a call from fire rescue. This boy was out on an ATV in the Everglades, fell off, fell on a rock, hit his abdomen, spleen punctured, and he arrived dead on arrival. Now, I had him the week before. I was really, truly affected by that because I was clear on my instructions. But you see, just simple little mono can be such a disease that we really need to stress. Now, any of you had that cough all night long, dry cough, can't sleep? It's one of those frustrating things. Your bronchus or tracheal bronchitis is another name for bronchitis. That's when, again, another virus. It's a dry, hacking cough, non-productive, that worsens at night and does not let you sleep. You don't get a fever, but usually how we treat this is with cough medicines to try to let you sleep. And, they actually, at this point, many physicians, even though it's a virus, do order one of those Z-Packs, some of the zithromycin. And it's a choice of the physician. And then the biggest thing is try to let them sleep. Now, croup is a laryngeotracheal bronchitis. So your larynx, your trachea, your bronchus is all inflamed. And this is the child who barks like a seal. It is barking, barking. You will know if you have a child in your office, in your urgent care, whatever, with croup because you can hear it. It's quite loud. Now, laryngeotracheal bronchitis, usually children under 5, and again, it's a virus that usually will cause it. Now, many times they've just had an upper respiratory, and then they start this barking. Now, when you think of anything on the upper side, upper airway, Remember, this is all has to do with the larynx, the epiglottis, and it has to do with swelling that occurs there. So what happens in laryngeotracheal bronchitis is the epiglottis starts to get inflamed. Now, what's that epiglottis? That's the leaf-like structure that covers the larynx when you swallow. Now, this epiglottis is now swelling and covering your larynx, your trachea. You're not breathing, right? Or breathing very little. So that's why you have these barking coughs, inspiratory stridor, okay? And if you don't treat it, it can lead to respiratory acidosis, a respiratory failure, or acute epiglottitis. You let that swelling continue. So now your whole airway is completely covered.
Is that
Now,
another word for like croup?
this is the end of croup that's untreated. This is the medical emergency of croup.
Okay.
Remember, croup is a swelling of the epiglottis. But when it gets to acute epiglottitis, it's really swollen. That means you didn't get the croup treated. It didn't take care of itself. You couldn't just ignore it. Now you're in a medical emergency. So what would a kid look like coming in with acute epiglottitis? Well, their larynx, their trachea is covered, okay? They're unable to breathe in. There's probably a little piece of air. That's why they're tripod leaning over, drooling, because they can't swallow. And they also, muffled voice will be there, and you're going to see respiratory distress. If you think a child has epiglottitis, you need to get an endotracheal tube in there, so an intubation tray and a tracheostomy tray. That's your priority because airway, airway, airway. No airway, nothing else matters. Now, I've never had to use it, but it is very, very scary. This child is restless, can't sit still, and is scared. So how do we take care of it? Well, I'm first going to calm the child down. If you calm a child down, you can, slow down this process of not breathing. So do that. Start an IV. So that's a hydration. Epiglottitis, croup. Well, some croups can get oral, but epiglottitis, no. Be IV, and we're going to be given steroids intravenously for your epiglottitis and racemic epi aerosols. So that epi goes right in the epiglottis and tries to decrease the swelling and let them, of course, try to breathe. Usually with croup, some physicians give one shot of a steroid, some give one pill of a steroid, and some give that prednisolone once or twice a day for 3-4 days, depending. It's all different. It doesn't, it's the physician choice at that point. But epiglottitis is scary. Make sure you're prepared for the worst in that one. So I told you that RSV in the little ones is a pretty dangerous thing, all because the extra mucus in the nose and the airway, they can't breathe. Suck, swallow, breathe, they can't. So they're in respiratory distress. Now, what if the kid's a congenital heart? What if the kid also has cystic fibrosis? What if the kid already has another immunosuppressive disease? Giving them RSV could be extremely dangerous. So there is an immunization. It's a prevention. It's a prophylaxis. And you need to know this name of this medicine. And it's Synagist or palvizumab. It's a biologic. And it's once a month from winter to early spring. So not a complete year, but only the first year of life, not thereafter. Because after that, the child should have been able to take care of themselves. Now, I think tonsillectomy probably is the most common of all surgeries for children of all ages, right? Tonsillectomies, and they do it adenoidectomies and tubes at the same time most of the time, right? So this is the treatment for post-op care. This would be your discharge teaching. Usually tonsillectomies go home. They're outpatient surgeries today. So parents and children old enough need to know. Don't have any foods that irritate or spice, like orange juice, no. Lemons, no. Any high seasoned, any good pepper, no, forget it. No gargling, vigorous toothbrushing. They shouldn't be coughing, clearing their throat, nothing in their mouth. Now, they used to give a hydrocodone liquid medicine to them, but today they realize that, don't take much of anything. So acetaminophen is actually a really good analgesic for them. As they get older and will tolerate it, there's an ice collar you could put on their throat. Younger kids don't tolerate it. That's cold, get it away. Don't upset them, don't irritate them. And older kids, eustachian tubes are right there, right in the back of the throat. They get clogged and they get painful. It's like going up in an airplane, your ears get all pressure. Chewing gum, same thing. It will break the pressure of the ears, and that will help with that pain. Now, remember tonsillectomies, adenoidectomies. They literally take a scalpel and cut the tonsils and adenoids out, and they cauterize the area. So postoperatively, there's a big scab that's left. That's why nothing in the mouth, no coughing, whatever, it could irritate that scab. So these children do need to rest for a week or two because all of those things can cause them to bleed. And I have met a little 7-year-old girl who came in vomiting chunks, clots of blood. And that was right after seeing her physician. And she was in hemovolemic shock. I had to bring her to trauma room and give her 1 liter of normal saline. Her heart rate was 180, her blood pressure was 60, and she was still vomiting up clots. She had to go back to the OR to be cauterized. So it can happen. Now, a little bit of pain, a little bit of mouth odor, it's normal. But if it gets worse and it persists too much, that child needs to go back. And remember, any kid that you see post tonsillectomy, they're over there swallowing, they're probably bleeding. Now, pneumonias can be caused for many reasons. Could be that you inhaled talcum powder, could be a bacteria, it could be from aspiration. All of these things could cause pneumonias. Now, we do have a vaccine now for the bacterial pneumonia, which is great. Now, years ago, we used to put talcum powder, and I love Johnson & Johnson baby powder. I thought it smelled really great. Put it on a baby, they smell like a baby, right? Well, we didn't realize that talcum was going in the air. They were inhaling it, and it was hurting their lungs. So no talcums around the baby anymore. Also, it's how you feed the child. Now, to overfeed them, it's going to cause reflux and it causes that aspiration pneumonia. These children need a proper amount of food. They need to be burped properly, and they need to sit up after they eat at least 30 minutes. And that can help avoid that aspiration. Another thing kids like to do is everything in their mouth, right? They love quarters, not a dime, not a penny. Most of the times I've seen quarters right there, that x-ray, and the kid's looking at you, and it's below the airways in the esophagus. And the kid's respiratory is doing fine, but that quarter is not going down. So we need to do something. Do you know how we take that thing out today? They used to go to the OR, do a bronchoscopy with little clamps, pull it out. That's a day admission, right? No, they take them today in the ER. They get the physician, a surgeon, takes a tube, Foley catheter with a balloon on the end, puts it down the mouth below the coin, blows the balloon up, and then sit that child sitting on that surgeon's lap. Lean them forward and say, cough, and they pull at the same time. And they usually vomit on the floor. Now, how do I keep that kid calm? I said, he's going to pull that out quick, and that quarter's going to come out, fall on the floor. If I get it first, it's mine. So the kid is ready. Once it's pulled, they always get it before I do. Now, I've distracted them. They're not worrying about the quarter anymore, are they? And then we just watch them, make sure their airway is okay for an hour or two later because there could be swelling. I've seen French fries occlude airways with really bad results. So, kids, keeping them safety, keeping small things away from them are very important. Now, pertussis is one of the vaccines that we give. So, why are we mentioning it? Well, we still have outbreaks of it. We did a couple of years ago have a pertussis outbreak. It's respiratory, it's highly contagious, and we treat them with antibiotics. And these children are usually because parents don't like immunizations. So, what does that mean in our care? Well, just because a kid comes in with looking like an upper respiratory, don't assume it's a benign virus. It could be something more. So always protect yourself and make sure you protect the environment, which is the other children. If you think it looks something different, put them in a reverse air room. Every unit, every ER, every urgent care all have it. Smoke inhalation injury, remember this is all upper airway. Sometimes there's swelling involved with that. Again, treatment is humidified oxygen, high flow, 100%. We know tobaccos and smoking around children shouldn't, whether you're pregnant or have children. So that's something we should teach. Now, cystic fibrosis. Sometimes we know the child's going to have it, right? A parent had it or there was a trait. They're now testing for this prior to birth so that you know if the kid will. Now, one of the ways, and this is one of the ways that you can tell, and I'm going to give some more as we go on with more chapters. A child who does not have a stool in the first 24 to 72 hours, they don't have any stools. This is one of the symptoms of cystic fibrosis. So they're going to do a sweat test. And why a sweat test? Cystic fibrosis loses sodium through the pores. In fact, if you have a child with cystic fibrosis and you tell the mother to lick their skin, it will be salty, high salty, which means you're never going to hold the salt on this child, okay? This is somebody who can have salt as much as they want. Now, cystic fibrosis is two organs. It's the lungs, thick secretions in the bases all over, like petri dishes, waiting for bacteria to come in and grow. It also is the small intestines and a lack of an enzyme for digestion of fats. And the pancreas is not working properly. So because of that, fats are not being absorbed. So you have these foul smelling, greasy stools. That's all the fat coming out. Now, do you remember nutrition and you look at carbohydrates, protein, and fats? Carbohydrates and proteins are 4 calories per whatever the amount is. Fats are 9. So that's like double the amount of calories. So these children will be small, even though they're eating well. So how would we feed these children? Normal salt, high salt, absolutely. High protein and high carbs. And we're going to decrease the fat, even with medication, because we don't want those foul smelling, greasy stools and abdominal discomfort. Now, the sweat test will come in. It's going to be high fluoride, sweat, it's salt. Absolutely. Just little stickers they put on. That's all they do and test it. Now, treatments, depending, is it the lungs or is it the intestines that's causing problems or both? Well, these children will be having multiple aerosols a day. Aggressive chest physiotherapy. These are the ones that get in those vests and that just, moves their chest to loosen it up. And remember, all these treatments should be done before they eat, or else they'll vomit, right? So always before meals. And that's to keep the airways open and mucus free. Now, how do we take care of the locking enzyme in the small intestines? Because that's where all the enzymes come from. We give something called pancreatase. That's usually the name. It's a pancreatic medication. And it comes in capsules. You can open it and sprinkle it on the food. There's little tiny little enteric coated beads. Those should never be crushed. Remember, anything enteric's never crushed. The powder form, again, we can put that on the food, but just like some of the upper respiratory medications, the Symbicort, the Advair, the Brio, done morning and night, that you have to rinse your mouth with, those are the ones that prevent bronchospasms. You have to rinse your mouth out to protect your tooth enamel. And the other thing that we forget, it's all different diagnoses. When you need a medication, remember that as you grow, you're going to need a bigger dose. I see this a lot even with seizures. Children in seizure medication hadn't been increased and they had a rapid weight gain or something, and then they had a breakout seizure. So keep the airway open. You're going to have bronchodilators. These children should be in physical activity. I mean, I always say swimming is an incredible sport for this. They have to hold their breath. That's putting PEEP into their lungs and keeping their lungs open. Again, aggressive treatment of pulmonary infections. They give oral and aerosolized antibiotics instead of just your bronchodilators, albuterol. They're going to give, like, usually gentamicin, tobramycin. Those are some ones we give in the aerosol directly into the lungs, and taking something also. The GI problems, again, it's replacing those enzymes, high protein, high calorie, right? And of course, a lot of salt. We sometimes these children do get intestinal obstructions. And when you start with giving the medications, you will see that their bowel's going to work a lot better because it causes constipation like it did in that newborn. And that's how we figured out they had cystic fibrosis. And they do have a lot of reflux. It's part of the whole thing with cystic. Now, one of the things with cystic fibrosis, because it has to do with pancreatic insufficiency, it can lead to diabetes mellitus. It's the pancreas, right? So remember that also. And cystic fibrosis, women can get pregnant. It's a high risk, but they can get pregnant. The problem is men. Because there is mucus forming in their vas deferens and their testicles, the sperm can't get to the woman. Now, 1 year after a bilateral lung transplant, they can get their woman pregnant, okay? That was a HESI question, so I made sure that I put it here. Children get a lot of sleep apnea. That's why they do those tonsils and adenoids a lot. It's all those snoring. It's adult children, same thing, sleep apnea, all that upper airway, and then being tired all day long because they're not sleeping well. They'll do that sleep study, and again, they'll do the tonsils, adenoids, and then at night they put them on this little machine up to their nose, and it blows in air, and it keeps that airway open. It knows what to do with it. At times, children get so sick or have been in an accident, or they've had a drug overdose, or they've almost drowned. They can go into something called acute respiratory distress syndrome, ARDS. This is something, like for instance, that near drowning, you can be 3 days and look okay. And up to 72 hours later, you could go into acute respiratory distress syndrome. That's why all drownings are admitted to a hospital, and all of them, O2 saturations are monitored in at least a step-down unit. Mortality rate is very high. This picture here, that is ECMO. Now, I was ECMO certified in my hospital. And what it does, it's like a heart-lung machine. It pulls blood out of the child. We oxygenate it and we put it back in. Has nothing to do with cardiac output. It's only giving oxygen. So they intubated and they're just letting the lungs rest. Usually with that, if we can then baby breathes a little better, turn the machine down, it comes off. But mortality rates are extremely high with this. Many of these children do die. Now, you should always review your CPR. There's always questions that look like it. Do you start chest compressions? Do you call a code? Those are things that you need to, read about. Also, remember, there's always a parent there. And remember, if they can't be at the bedside, and today let's promote them to stay in many cases so they can hold their can in case that child dies. But remember, somebody should be with them. It is extremely stressful. Their kid is in there coding. You see all these people, and it's very difficult. Asthma, very, very common childhood illness. This is a lower airway, and its airway air can go into the lungs, and it gets trapped, and you can't get it out. So this is expiratory wheezing. This is not inspiratory stridor of the upper airway. You need to remember that. Upper airway is inspiratory. Asthma, lower, is expiratory, prolonged expiration, because trying to get the air out is just very hard, okay? Asthma is usually due to some sort of hyperresponsiveness to something. Usually there's an allergen. So once we determine a child has asthma, and they wait till about age 2 still today, they're going to do pulmonary function tests, skin testings, see what the kid's going through. Sometimes skin testings try to make them, not allergic to those things to help them. But even with asthma, kids can be normal as long as they have their rescue inhalers with them. And if they're allergic to grass, they shouldn't be playing soccer or football, right? Maybe swimming or tennis would be a better thing. Be normal, okay? We can prevent those asthma attacks by using those long-term medications. That morning and night medication, they have the Symbicort, Advair, Brio for adults. The child is Pulmicort, and they give an aerosol. And it's that little bit of steroid to prevent bronchospasms. Then, of course, we got the quick relief ones. And if we need to, they can have steroids, the corticosteroids, to help relieve the inflammation. My husband, several years ago, went into status asthmaticus. He was admitted to the hospital, not breathing well. And at 4 o'clock in the morning, he went into status. And he stayed there for 12 days. And it is a very scary, scary thing. And all I can tell you is with children, number one, try to keep them calm. Whoever can keep them calm, however they can keep them calm. If mom has to climb in bed with the child on top, do whatever you have to do. It's no matter what you do, they're not ventilating. Most of these children will end up intubated. I was lucky because I could calm my husband down and he never needed intubation. And he went really bad. His heart rate would go up to 200. His O2 sats would go into the 80s, but they let me work with him, or else he would have ended up there a lot longer than only 12 days. We know COVID out today, our virus, there's no cure. There's all different sort of symptoms that go on. Now, cardiac. So when we talk about children, we usually talk about congenital heart defects. That means these kids were born with this. If you knew what happened to a heart and what it had to go through, you would think more hearts were not formed correctly. Now, it can be acquired in time. An infection, usually viral infections, causes cardiomyopathy or that heart getting big and floppy, all right? Autoimmune, well, what does lupus do? It attacks organs. Could be environmental, of course, or familiar. Now, do you remember the um, pathophysiology and all the names of the things in the heart? Do you remember the valves? Do you remember the tubes? I'm going to go over it quickly with you. Something you should think about. And think about, I'm going to go and follow a trace of blood and think about it as a garden hose. Because when I'm done, I'm going to put a kink in the hose and I'm going to show you what happens. Okay. So blood comes through this inferior, superior, or inferior vena cava, goes into the right atrium. Ooh, it just gets there. So it's really slow going in. It goes through the tricuspid valve to the right ventricle, goes up through the pulmonary valve into the lungs, goes back to the left atrium. It's actually 4 pulmonary veins. I didn't know that. I thought it was 1. It's 4. So a lot of flows going into that left atrium, goes through the mitral valve, goes into the left ventricle, then it goes to the body oxygenated through the pulmonary valve, to the aortic valve, up to the aorta. Those 3 little tubes on top, it's going to the upper body. Subclavian carotids, it's going upwards, okay? And it goes over the arch. Okay, put a kink right there at the right after those 3 little ups, put a kink in it and make the blood flow like just a little bit getting through. So the heart's pumping, right? That left ventricle is still going to pump, trying to get blood to the body, but it can't. So what are you going to see? What is going to be that diagnostic tool? And it's really just an assessment. Well, that aorta feeds the body and goes to the feet. In the feet, you have pulses. What do you think those pulses would feel like if hardly any blood's getting there? They're going to be decreased or they're going to be absent. Also, take a blood pressure on those lower extremities. Not much blood's getting there. So guess what? Your blood pressure is going to be lower. Now, let's go to the upper extremities now. That's where the blood is trying to get in and it can't go. So where is it going? Well, it's going to the upper body, subclavian, carotid, right? It's going up, but it's also going back into that left ventricle, stretching it, and it's going up to the left atrium and up to the lungs and filling up. Now you're in congestive heart failure. Do you see how that garden hose just worked? So think about those things as you are, looking at these heart things. Coarctation of the aorta is what I just described. One of these things that you're tested on. Seen it on HESI, and they've told me it's on the NCLEX before. Now, a lot of times children go home really quick after birth, right? And maybe it was missed. Some of these cardiac coronary things that go on there. And I actually had a 3-month-old girl who was a coarctation who had these symptoms. So let's go over them. So if your lungs are filling up with fluid, your heart, the ventricle stretching, blood's not getting where it needs to go, you're going to tire out easy. So poor feeding. You're going to see them that can tachycardic because the lungs are filling with fluid. The body wants the oxygen. Now you're burning up all of these calories and you're not eating that much. So failure to thrive with your poor weight gain. Of course, no activity tolerance because you can't breathe. And then you're not getting nutrition, cognitive delays, right? No nutrition, newborn cognitive delays. Now, sometimes we know, sometimes we don't. But it's something that we see those symptoms, many emergency rooms that little girl went to, they didn't know cardiac on children. So she went almost 3 months before she came to our cardiac unit and then was found out what she was. So one of the nursing diagnoses for these especially this is a child who's not gaining weight. It's that inadequate oxygen perfusion leading to activity intolerance, resulting in diminished breastfeeding. So that would be something that you would see. So when we look at a kid, that's coming in born, newborn, or child that's going into the cardiac ICU, because we know we're always going to look, nutritional status. Are they eating? Are they gaining weight? What's their color? Do they turn blue when they're eating? All of these things. Chest deformities, murmurs. How are they breathing? As they get older, not at birth, it takes a while. You'll see those clubbing of fingers. And I have a picture later on. I'll show you that. You're going to look at the chest, feel the chest. You're going to look at the heart rate, blood pressure. What is the cardiac rhythm? And we're going to do number one, they get an EKG. That's like guaranteed, number one. And then we're going to do an echocardiogram. That echocardiogram, if we see anything, prepare the family. They're going for a cardiac cath. Now, it could be a diagnostic because we're trying to figure out this kid have, I don't know. So we'll figure it out with a diagnostic. And the interventional or electrophysiology studies are actually for those, and I've seen it mostly with tachydysrhythmias. They're intermittent periods of time where the heart rate goes really fast and slows up. And they have found this usually through those 24-hour Holter monitoring, and they're on medication and they're old enough now. And the physician goes in, recreates that tachydysrhythmia, finds out where it is, and he zaps with a laser and stops it. So it is a cure for that intermittent elevated heart rate that's been going on. We had a really great doctor that I worked with that did them. So now we've had a cardiac cath. We have found out whatever the child has, and you have received that child back from cardiac cath. I mean, getting them to cardiac cath, you just have them NPO somewhere between 2 to 4 hours before the procedure. That's it. Of course, getting your chart ready. Post, when they come in, remember cardiac caths, they take two big catheters and insert it in the pulmonary artery and the pulmonary vein. And they take them out when they're done. The dye, none of that bothers them. They usually do really well. You might have some tickling, some dysrhythmias, but that's normal. But when they pull those catheters out, they have to hold pressure, usually with their hand, hold pressure until it clots off. Then they put a pressure dressing on it. Older kids have a sandbag put on there. Now, then they're taken off the table and come home to your bed and placed on your crib, your bed, whatever. And that movement sometimes dislodges the clot off of those femoral artery or vein, okay? So, number one, check the dressing. They can bleed out quick. Think about a newborn baby, which is most of your congenital defects that you're doing cardiac caths on. I mean, they can bleed out extremely quick. So that's the biggest risk. What would you do if you saw a baby bleeding? You take your fingers and you're going to put pressure right above the bleeding, closer to the heart, and you're going to call for help. And that's all they're going to do, really, is watch it till it clots off and re-put on a dressing on these children. And then, of course, if it's a lot of blood, they'll do a CBC. And if it's a real lot, they're going to transfuse, okay? So once you've checked the dressing and now it's not bleeding, you do pulses on the lower extremity. Not uncommon. That right leg is going to be a little bit less, okay? Looking, capillary refill, all of those things you're going to do, vital signs. They need fluids of some sort. Remember, infants, we need to check blood glucoses. Did they get enough glucose in the lab, or did they get too much? We need to know where they start from, because we don't want blood glucoses of 20. They say low glucoses will burn brain cells. We don't want to do that to no child. So congenital heart disease. Major cause of death in the first year of life after prematurity. That's how big congenital heart disease is. Most common is ventricular septal defects, and most of them are Downs. Downs is the biggest one for congenital heart defects. You have an infant born, you want to work in L&D, have a Downs child born, check the heart, see if there's a murmur. That usually will be it. Now, heart defects, a VSD is still having oxygen go around. That's what we call an acyanotic heart disease. There's enough oxygen is getting where it needs to go. But there are acyanotic heart diseases where they're not getting oxygen. What would happen if you didn't have a tricuspid valve? How are they getting blood to the pulmonary artery? They're not. So we're going to go into what we do there in just a second. And remember, blood in the body, in the heart. Remember, the right side has just a little bit of pressure from that last part of that heartbeat. And remember, that left side's got a lot of flow coming in. So blood always goes left to right in the heart. And that's what we call shunting. All right, this is in your book. You can look at this also there. So, as I said, ASD, VSDs, blood's going to shunt always to the right. When it goes back to the right, what's the path of blood? It goes back to the lungs. So that's increased pulmonary blood flow. Now, a patent ductus arteriosus. You learned about that in maternity. That's fetal circulation. Whenever you think of a patent ductus arteriosus or a PDA, think about, this is my way to give oxygen. It connects the pulmonary artery to the aorta. So lungs to body, pulmonary artery to aorta. Makes sense, right? Now, with that tricuspid atresia, if that PDA maintains open, we've got oxygen getting to the body, okay? Very important concept there. I've already talked to you about coarctation. And remember, stenosis is a narrowing. An atresia is A without. There's nothing. And that's what I was discussing, tricuspid atresia. There's no opening. There's no oxygen going to the body. I need oxygen. Oh, PDA. Let me get the oxygen to the baby. Now, occasionally, sometimes the aorta and the pulmonary artery are switched. And that means the lungs are going this way and the body's going this way and there's no oxygen. I need oxygen. Oops, PDA. I need to keep it open, okay? And I'm going to tell you how in a second. The most difficult and hardest and worst, per se, devastating for many parents diagnosis is a hypoplastic left heart syndrome. They probably are the nicest parents of all, too. The left ventricle is thick and narrow, small, and the heart don't pump. And it's going to require 3-day surgeries. It's going to 3 stages of surgeries and all sorts of stuff. And it usually ends up in a transplant. Hypoplastic left hearts. I've got many of them that are dear to my heart 20 years later. So, the oxygen tube, PDA. How do you know it's open? Well, you're going to hear, with your stethoscope, a loud washing machine murmur. Very evident. You also, cardiac children will all have some sort of central line, an umbilical artery catheter, usually, right? And they have a blood pressure up on the monitor. Now, a newborn's blood pressure, like I've said, is 60/40. A child that has a PDA that's open, working, giving oxygen to the body, would have a lower diastolic, like 60/18. So those are 2 ways you would know without even an echo, right? Now, they usually close within the first 3 weeks of life, usually within a couple days. So that PDA we got to do something. Well, what it was is intrautero, mom produced this hormone called prostaglandins, and it kept that PDA open. When you're born, mom's supply is gone. So it closes because it doesn't have prostaglandins. So we do have a synthetic prostaglandins, and we give a slow, continuous infusion. And what does that do? It gives baby oxygen and keeps them alive till we can do surgery. It maintains cardiac output, and it also gives them the oxygen they need. Now, sometimes you have premature infants, usually, not all the time, but their PDA doesn't close. You're not giving them anything, it's just there and it's still open. So we can actually close it with medications. And we close it with this medication. It's IV, it's 3 doses. Sometimes we repeat the 3 doses one more time, but it's called indomethacin. It's actually an NSAID. When I first heard indomethacin, I'm like, that's what you take for back pain. And they're like, no, it's IV and it works. How would you know it's working as you were administering it as a nurse? The murmur would disappear. You're not hearing it. And guess what? That bottom diastolic number is going to go back to 40 or close to there again. You know it's closed just by looking at that. There's a bunch of different pictures there I have for you that you can look at, but I've explained it to you, I think, pretty good. Now, congestive heart failure. One of the things that you're going to have a child whose heart's not working well for whatever reason, and blood's not pumping, and the lungs are filling up. It could be the right side, there's a kink, or the left side, there's a kink. It could be either that's causing it. You're going to see a child full of fluid, the x-ray is going to show it. And what do we need to do? Sometimes you see a rapid weight gain because we weigh our children every day on the same scale every day. And we're looking at their weight. Are they gaining weight normally just because they're eating? Or are they gaining weight because they just gained a lot of fluid in their body? So with congestive heart failure, the heart's not beating well and you're full of fluid. Need to give digoxin, right? Let that cardiac function did better. And we want to remove the fluid, furosemide. Both those drugs are used with infants and used very well. And they've used them since the 80s that I know of, okay? So your heart's beating better, your fluid's coming out, and now your oxygenation is much better. And you would see the weight go down because now they've lost the fluid. Now, giving digoxin is just like infants. I have a whole dissertation here all about it. Remember, digoxin on adults, apical pulse, 1 minute, check the potassium, check for drug levels. With infants, can they tell you they see yellow spots, they're nauseous or anything? Absolutely not. But they'll vomit, won't they? That you can see. If you see an infant vomiting, that kid has a possibility of being digtoxic. It is better, and to be safe, check a dig level than it is for you to just give it to them again, because dig toxicity would be worse. Then you're giving digibine and all that good stuff, right? The antidote. So that's dig. Now that's your picture of clubbing. You see the fingers there? Those are usually your children, like your hypoplastic left heart. Those kids are really do have a lot of clubbing and decreased O2 sats. Do you know that hypoplastic left heart child will be born with O2 saturations? Could be 65 to 75, and we don't put oxygen on them. That is just fine for right now. After stages of surgery, you might get it up to 90 or 92%, but you can see their O2 saturations are low. So what does the body do when it's upset? It doesn't have enough oxygen. It says, if I had more red blood cells, I could carry more oxygen and I'd feel better, right? So they start producing red blood cells and red blood cells. And your hemoglobin goes to 18/54, hemoglobin hematocrit. That is called polycythemia in a nutshell. Polycythemia is the body just trying to get oxygen to where it needs to go, but there's no oxygen to be had. Again, always include family in everything. Remember, these kids are going home with mom, caregiver, dad, aunt, uncle, grandma, whoever it is, whoever's going to be caring for them. I talk to everybody, tell everything as I'm doing things, especially on infants, in a very calm little voice. I'm talking to the baby, but I'm talking to the parent. This is what I'm doing. This is what I'm looking for. This is what I see. And letting them know what's going to happen to their child because in a couple days or soon their chest is going to be cut open. They're going to come back with an incision on their chest and 4 chest tubes, and they're intubated and they can't move, and that's extremely scary if they're not prepared. I already did that one. Bacterial endocarditis, just like adults, you're going to be giving prophylaxis for it. Now, there's 2 different conditions that are caused by a strep throat that hasn't been treated properly. The one in the cardiac chapter is rheumatic fever, and it has a bunch of symptoms. It affects the joints. You have swollen nodules. You get a rash on your skin. You have something called chorea, which is you can't control your movements. And these children come in usually because of the movements. They've gotten to that point. And we say, so have you been sick lately? What have you seen? And if they say a sore throat, they're going to be doing what we call an ASO titer. It's an anti-streptolytin titer. Strep is in there. And that's going to say, yeah, you have strep. So it also can affect the mitral valve and damage it severely at that point. So treatment is long-term, months, 2 months, depending on how long it takes, antibiotics. But if that valve was damaged, it's nothing we can do. It's not going to turn around. Everything else will go back to normal, but not the heart. Kids can have high cholesterols. They can have dysrhythmias. The smallest child I saw because of a Brady dysrhythmia was 18 months, had a pacemaker. Little, tiny little thing. Pulmonary artery hypertension, just like adults, lungs are damaged. They get tense. They're not exchanging oxygen and carbon dioxide. So they're always starved for oxygen. So they're dyspneic when they exercise. They don't get oxygen. When they get chest pain and tightness and dizziness, again, no oxygen. Cardiomyopathy, like I said, could be due to many things. Could be that viral infection, metabolic problem, collagen disorders, all of these things. And again, it's a stretchy, floppy, big heart that's not working right. And most of the time, those children also go for transplant. Now, post-transplant, the biggest thing that we're concerned about is rejection. Okay? Infections we can treat. Rejection is the largest reason for death in transplants. Now, after surgery, children get chest tubes. You have cardiac surgery, there's chest tubes in. And we need to know how to take them out the best way for children. Well, children get anywhere 1 to 4 chest tubes. I've seen 5 in little infants, yes, these big, and they are painful. So, of course, they're medicated, post-operatively. Yes, they have, these continuous narcotic drips and it's fentanyl they give to help them. But once they get to the point, they're extubated, need to take out chest tubes, they will, you need to give them something for pain. And that's priority. Do never let a physician come and apply the chest tube without giving them medication. I worked in the adult cardiac unit too, and I worked night shift. And at 6 a.m., they pulled out all the chest tubes. So I've spoken to many adults that tell me when they pull it out, it burns. And it's not a long time. It's like 30 seconds, 20 seconds, but it feels like a lifetime as they're feeling it. So number one, if you're going to give a narcotic, take your vital signs. Give the pain medicine. Let that child on their developmental level know what's going on and be honest. Tell them it's going to hurt a little bit. but it goes away quickly. You want me to hold your hand? We can count to 20 together. And sometimes that's all they need. We didn't check blood pressures on young kids for a long time. Now we're checking them on smaller and smaller kids. We're finding they're walking around with high blood pressure at earlier ages. Kawasaki disease. We say it's a cardiac problem because it is a systemic vascularitis, or all the vessels get inflamed and they, like little microemboli go around, but the coronary arteries, which is a vessel, right, can get an outpatching aneurysm and could burst. So that's our biggest concern with it. Now, these children are usually younger than 5, and you're going to see the biggest, reddest glow in the dark eyes at the acute stage. You're going to see a strawberry tongue, cracked red lips. Sometimes, the lymph nodes could be elevated. The palms of their hands, soles of their feet could be blistery or cracky, skin going on there. And that is Kawasaki disease. And again, we want to treat it before the aneurysm occurs and this blood vessel is vascularitis and microembolus. So what are we going to do? Well, it's a virus. We're going to give IV immunoglobulins, IVIG, and we're going to give high dose aspirin. And yes, aspirin. This is the child that will get it. And why aspirin? It's an anticoagulant. It helps with the clots, and that's why we give it. Some physicians choose to give a Coumadin instead of aspirin, but I've always seen aspirin given. That's all your thing about Kawasaki. Shock. What is the most common cause of shock in infants? Sepsis. Sepsis is what we see the most of the time. I've never seen anaphylaxis in a child and giving any antibiotics. It's always sepsis. So remember, if there is an anaphylaxis, treat it just like adults, right? We're going to protect the airway, give epinephrine, and we're going to support them. Septic shock, again, we're still going to give, intubate them if they need respiratory support. If they need any sort of vasopressors for their blood pressure, we're going to give it, but we're going to start those antibiotics and we're going to try to get those antibiotics in before we get to the point of shock. Adolescents, toxic shock, that's your tampons, and it's something that we need to teach them about. So here we are. If we had a surgical closure of that oxygen given place, right, the PDA, that would result in what? You close the PDA. Remember, connecting pulmonary artery to the aorta, lungs to body. You're going to cut it off. What's going to happen? Remember, blood flowing, shunting back and forth.
C.
D. Doesn't it do anything to the oxygenation? The oxygenation will still be there, right? But what it does is the aorta, that left ventricle is pumping, and it goes back into the lungs. So it prevents it. It also works the other way where the lungs can give the aorta the oxygen also, but it does prevent it. So that was the answer there. So am I overwhelming you yet with all of this stuff? Did you follow it a little bit? I hope. Well, we're going to do a cahoots and find out, right? Who wants to win tonight? Okay, Kirsten, I know you do. Libby, you going to fight her too? I hope it's a friendly fight. All right, let's get going. If you're coming in, just keep coming in. So, week 5, almost halfway through already. It's crazy. A majority of upper respiratory infections are caused by what? And again, remember, it's viruses. Respiratory infections, they're going to go right to viruses until proven otherwise. You walk into a 6-year-old child's room and you find them not breathing and does not wake up. What are you going to do? There's a 6-year-old child. You are going to start your chest compressions immediately. They used to do the 2 deep breaths first, but they realized there's enough oxygen in your system you can go for a while. I mean, realistically, you in a hospital, there's buttons over the bed. You push the button and you start at the same time. But they say chest first. It's a scary thing to find. I found them before. What are signs and symptoms that smaller children may exhibit that has a respiratory infection? What's a little kid going to look like? They have a respiratory infection. You know, you and me, we're sick. We're still going to eat. Oh, I'm going to have that McDonald's cheeseburger, right? Kids, nothing you can do. They didn't want French fries. Everything, fever, vomiting, poor appetite, abdominal pain, one or all of them they could have. A multi. What do you look for when assessing respiratory function? We're going to look at a little bit of everything. And you know, when you look at children, what's pretty neat, when we know that they're not breathing well, when they right between the clavicles, right here, it pushes, I call it retracting to their backbone. It's so significant, not adults. In children, you'll see that big hole, supraclavicular, right in there, push. But all of those things involved too. What would you look for after a child that has a tonsillectomy? What did I tell you? If they're swallowing, they just had a tonsillectomy, what are they swallowing? They're swallowing blood. So swallowing more than usual is your answer there. It's always been a question. Nursing care for a child status post tonsillectomy includes I had my tonsillectomy when I was 21 years old and it hurt. But at 21, I lost 5 pounds and I was happy, right? Remember, pain management because that keeps them calmer. No spicy foods or orange juices, any of those things. Remember, gum for the older kids because it's like their ears get clogged up, like going in a plane. It helps them pop. And if they can tolerate it, yes, ice bag. Younger kids won't let you. Multi. What would you suspect if a child had a dry, bothersome cough that keeps them awake at night? Or I tell you, this is the one that we're going to treat it with some cough medicine. Maybe it's usually a virus, but they put them on a Z-Pack to be sure. Remember, bronchitis, the other name is tracheobronchitis. Those words are used interchangeably, okay? Asthma is not a dry, bothersome cough. It's hacking, it's expiratory wheezing, okay? And of course, pneumonia is that productive wet cough. A multi. What signs and symptoms would you see in a child with otitis media? So remember, ear pain is always your priority. Take care of the pain, okay? They can have ear drainage. It doesn't mean it hurts more or less. It just means the eardrum ruptured and now it's spewing out. And of course, they don't feel good, loss of appetite. And they don't always have a fever. They just don't. Some of them has never had a fever. The monthly immunization for RSV is, and that is Synagist. Humira, that's for RA. Indocin or indomethacin is to close a PDA. All of the following are signs of early respiratory distress in children, except I like to do a lot of the except questions. It makes you think which one isn't right. That means you have to know what the symptoms are. Now, in early respiratory distress, you are tachypnic and tachycardic. You're not bradycardic. If a child is in respiratory distress and bradycardic, you need to get him to a trauma room. That child is going to code. It probably needs some sort of respiratory intervention now. A 4-year-old child's been taking meds for asthma and they're still wheezing. What information is important? What should you be asking? They're taking their meds. They're telling they are, but they're wheezing. Now, have any of you ever tried to take an MDI, meter dose inhaler, take a puff and breathe in at the same time? Well, a child can't do it many of the time. So what they do is they put it on what we call a spacer, plastic tube. They have masks that go around that are all shapes and sizes. And it's the tube come out, and on the end, you put in the inhaler and you puff 1, 2, whatever the dose is. That kid breathes in and out a couple times, they got their dose. Many times, especially younger kids will cry, but you know something? They're getting the medicine as they cry, they're getting it deeper. So it's really okay. An 8-month-old with croup exhibits what signs and symptoms of respiratory distress? An 8-month-old croup. So, all the other answers, a heart rate of 25 and 108, that's just normal. Pulse ox 95 is fine. Respiratory distress is less than 90% in children. Abdominal breathing pulse 100, that's fine. But the substernal retraction, and now they're restless. Now they're hypoxic, right? Restlessness. That was the key there. Signs and symptoms of asthma include all except. So they have a prolonged expiratory phase, right? The air gets trapped down, they can't get it out there. trying to get it out. They cough, short of breath, wheeze, all of that. Yes, but they have a prolonged expiratory. Signs and symptoms of congenital heart disease include all except you got a heart that's not working good, congenital heart defect. Body's trying real hard to get blood around and oxygen. Body's working really hard here. So they're not going to have weight gain the way they should. They're burning calories like crazy because they're poor feeders because they tire easily and they're tachycardic and tachypnic. What should you not do to children diagnosed with croup and epiglottitis? So whenever you have upper airway swelling, because remember, croup is the swelling of the oral pharynx and the epiglottis, and epiglottitis is all epiglottis is swollen. Nothing goes in there because you're going to increase the swelling. They say only a person who can intubate should be looking into the throat, especially with a tongue depressor. They don't use them. The epiglottis is the what? What is the epiglottis? It's all of them. It's that leaf-like structure that covers the trachea so that you could swallow and not choke. Yes. A multi. Treatment for infectious mononucleosis. Mono, the kissing disease. What's the big deal here? Remember, it is a virus, an Epstein-Barr-like virus. So antibiotics are going to do nothing. And remember, just rest, antipyretics, fluids, no contact sports, protect that abdomen or it's going to burst. Multi-select. When doing an admission on an infant that has a low-grade fever and a loose cough, what information is important? You're doing an admission and the kid just came to the floor. What do you need to know about it? What's important? I know as a charge nurse, I would always be infected, non-infected, which ones can go together, medical, surgical. So immunization status is important because remember that loose cough could be something like pertussis. So if we know they have immunizations, we know we're pretty okay. Of course, what is their fever and Tylenol, Motrin, when do they take them? So I can take them again. APGARs at birth really are not important. NICU, 2-month admission history, that's important, not APGARs. What is cystic fibrosis? So remember, cystic fibrosis is a two-system problem. The lungs get clogged and the digestive or small intestines get clogged up. It's two of them together. So double whammy for that mother and father. What is the greatest risk for an infant having a cardiac catheterization? What did I tell you I'm concerned about when I get those kids back from the cardiac cath? And it's all about the hemorrhage, okay? They're not gonna, as I said, they don't get allergic reactions, they don't have dysrhythmias usually post, and they're gonna have slightly decreased pulses because of the catheters that are in there. The big priority is check the dressing for any hemorrhage that's going on there. Save the child from bleeding out. So how is cystic fibrosis identified? Well, will be suspected if they have constipated at birth, right? No stool for the first 2 days. We can suspect it, but then how do you identify it? What's the test? Of course, newborn screenings and sweat tests. We're looking for sodium. Remember, the skin will taste like salt, like really salt. A multi. What's included in the plan of care for a child with cystic fibrosis? So remember, these kids are sweating salt into their pores. So you would never, ever have them on a low sodium diet. They can't absorb fat. So what do? High protein, high carbohydrates. Their lungs are full of junk, aggressive chest physiotherapy, and to be able to at least absorb some nutrients, pancreatic enzymes directly before meals, not an hour before, directly before meals, either sprinkling it on or taking the capsules as they get older. What is a drug of choice for the pharmacological closure of that oxygen device, PDA? How do we close it? Usually those premature kids. And they stay open. Why do they stay open, right? And it's called indomethacin. So remember that PDA keeps open with either mom's hormone of prostaglandin or the synthetic that we give it. After birth, it goes away, it closes. If it doesn't, indomethacin, 3 doses is given, sometimes repeated one more time, and it does pharmacologically close it. If that don't work, it's surgical. So, what is not a feature of tetralogy of Fallot? Now, let me tell you, tetralogy of Fallot is a pulmonary artery that closes up and blood can't get to the lungs. So it's all right-sided stuff that work with tetralogy of Fallot. So if you think that pulmonary artery is closed, kinked, and it happens suddenly, that blood's coming in, so now it sort of stretches that right ventricle and goes back. There is usually a VSD on these children. I had a child do a TET spell. That's what those cyanotic spells are called. 4 o'clock in the morning. And what do you do as a nurse? And you're allowed to do this without an order. It's called a knee chest. So whether you pick the knees up to the chest on their back or on their side, and it's a quick. The pressure from the abdominal cavity and the chest cavity, that going like that changes the pressure in the chest and opens up the pulmonary artery and now lets blood flow. This little boy, Nolan, I'll never forget his name, went from an O2 stat of 100 to 10 in like less than a minute. He went from pink to black. It was impressive. It's the only TET spell I ever had on me before. All I did was change his diaper, wipe his lips off. What medication would you hold for an infant that is vomiting and vital signs are 98, 88, 32? And by the way, all of these medications are used on children. There isn't children cardiac medication. There's just doses made for children, like milligrams per kilograms. And yes, the keyword was vomiting, heart rate 88, digoxin. Hold it, call the doctor, get a dig level. Be safe, not sorry. Why would a child with tetralogy of Fallot not gain weight at a normal rate? Again, this is a cyanotic heart disease. This is the one that you will see on HESI and NCLEX, tetralogy of Fallot, something you should read a little bit about, okay? It will come back. They don't talk about all of the other ones. Coarctation, tetralogy, always will be seen further on in your HESI and NCLEX. Again, inadequate oxygenation, which leads to decreased energy to feed. This is, again, another congenital heart. They're working so hard to get oxygen around, and they just can't eat. And they're going to be smaller, absolutely. 25 percentile. All are examples of a cyanotic heart murmur, except well, I already told you tetralogy is congenital. I've explained what tricuspid atresia is. It means A, no opening between right atrium, right ventricle. Definitely cyanotic, right? So an osis is still an opening. There's movement. And it just means blood is getting a harder time to go out the aorta to the body. And in ASD, it's extra pulmonary blood flow, right? Because if the blood is going from the left side to the right side and back up to the lungs again. What is the most common cyanotic congenital heart defect? Most common. Cyanotic. And it is tetralogy of Fallot. PDA is your oxygen tube. That is definitely acyanotic, okay? Nursing care following a cardiac catheterization. So we're definitely going to be looking at that kid when they come back from the cardiac cath. We're going to be checking that insertion site, checking pulses. Again, that leg, the right leg that's had those two catheters, keep it straight because it could dislodge the clot. And these children and adults, cardiac cath, they need bed rest 24 hours. And that's to protect those clots so they don't bleed. Multi. Nursing education for the cardiac catheterization include all except. So remember, you can't ambulate 24 hours bed rest, and you need to keep that right leg straight. You're going to be monitoring vital signs, and you're going to have a pressure dressing there. Absolutely. Which information is most important when rheumatic fever is suspected? What did I tell you rheumatic fever was due to? And when we get to week 8 and we do acute glomerulonephritis, it's another thing that it can cause also. So there's 2 of them. So it's due to strep infection that wasn't treated properly. How do we treat it? Long-term antibiotics. And remember, if it's already hit that mitral valve and it's damaged, there's nothing we can do. We just have to deal with it. Signs of shock in children include all of the following except. What is shock? What do you see? In shock, whether you're kids or you're an adult, you're going to see heart rate is going to be very elevated. Blood pressure's on the floor, poor capillary refill, poor urinary output, altered mental status, all of these things you see in shock. The body's trying to clamp in and everything goes central. Which of the following best describes the pathophysiology of Kawasaki disease? And it's a multi-system vascularitis, and our concern is that the vascularitis hits the coronary arteries and causes an aneurysm, and that would cause death. A multi. A clinical manifestation of Kawasaki disease is, I used to love trying to diagnose these in the ER, and I found quite a few in my career. They're very difficult to see because sometimes you don't have all of the symptoms. And it's all the above. The chorea is actually part of the rheumatic fever, remember? So it's that blistered hands and feet, strawberry tongue, and those eyes. I'm telling you, they glow in the dark. You'll never forget it once you see it. What's the treatment for Kawasaki disease? Remember, it's a vascularitis. There's micro pieces of, emboli that's going around in there, and that's part of our concern. And remember, it's a virus, so no antibiotics are going to do nothing. So it's aspirin, high dose, or Coumadin, and then the intravenous immunoglobulins. And that's about a month of treatment, usually, a month, maybe a little bit more. And it doesn't mean once you had it, you'll have it again. Which of the following is the most common cause of shock in infants and children? What did I tell you? If you ever get the chance to work in a nursery or newborn ICU, children and infants that are starting to get that infection will have periods of apnea and bradycardia. It's very subtle and usually no fevers yet. And that's telling you they're going in having an infection. So it's sepsis, infection, that causes shock. That's the biggest cause. What are the defects associated with tetralogy of Fallot? Remember, it's that right side. So do you know which of these are all right-sided diagnoses? And remember, it does have that opening, that VSD between the septums, the right and the left, there's a hole between them. So it's all about the pulmonary artery, that VSD, the aorta sort of moves over. That's what that misplaced means. And remember, if blood can't go up, that ventricle will stretch. So it's hypertrophy is when it gets stretched. That's the name. A young child with tetralogy of Fallot may assume which position naturally when having a TET spell. Now, just because they have tetralogy of Fallot does not mean they're all fixed, as an infant. Some are older. And remember how we fixed the TET spell? Well, they do it themselves. And like the picture shows you, they just squat, poof, and it stops them. So they just squat. It puts the abdomen up to the chest, changes pressure, and they do well. Transposition of the great arteries. TGA, what is that? Well, what does transposition mean? So that means the aorta and the pulmonary artery are switched, and they need to give them oxygen. Put a PDA, keep it open, and then they do surgery, okay? What they do is an arterial switch, it's called, and they switch it. Now, sometimes with transposition, just getting that PDA open is not enough oxygen. So at birth, you're born with a small hole between the atriums, right? The patent foramen ovale. They go up and they put a balloon and they punch the hole bigger. So now you'll have right to left side now moving around a little bit easier. So those are the treatments for that. So, which is not, the following is not an intervention indicated for transposition of the great arteries? Anything oral is going to do nothing. So prostaglandins, PDA, we got oxygen going. Switch is the surgery. They turn them around. And that balloon atrial septostomy is when they punch that hole through the atrium, creating more blood flow. A multi. Why is prostaglandins given to a child with transposition of the great arteries? What does prostaglandins do? Remember, prostaglandins is the hormone that mommy has that has fetal circulation. That's your PDA. And at birth, mommy's gone, so we give it to that child. It helps with oxygenation and it maintains cardiac output. It is not an antibiotic, it's not used for infections. It's a hormone to keep the duct open to allow oxygenation and cardiac output. What is the purpose of giving indomethacin to a neonate with a PDA? So remember I told you sometimes premature infants is still there and they need prostaglandins to keep it open and somehow they have them. So what indomethacin does, it stops whatever prostaglandins there, they say go away, be gone, and then the PDA closes. Where is the patent ductus arteriosus? Where is the PDA? What does it do? What does it connect? Remember, it's my oxygen tube. What does it connect? Oxygen, pulmonary artery to the body, aorta, pulmonary artery to our aorta. This heart defect allows blood to pass from the left ventricle to the right ventricle. So if it was going from the left to the right ventricle, there's a hole there, and it's called a septal defect, as in ventricular septal defect, VSD. If it was in the atrium, is an atrium septal defect. Okay? A multi. What is the sign of dig toxicity in infants? So you can't see yellow spots. I don't think an infant can tell you that. That's adults, okay? But nausea, vomiting, and heart rate, you can absolutely see. Dig toxicity. You see that? Hold the dose, call the doctor, get a level. What is congestive heart failure? So when the heart can't beat right or it's, fighting against some sort of restriction, this is when the fluid builds up and it can, all the lungs, it's a space where fluid can go and it causes fluid in the lungs. Congestive failure. Left-sided congestive heart failure causes what? So if the left side is full of, the heart's not working, what happens here? It goes backwards up into the lungs. Yes, excellent. Good job. After a heart transplant, what is the leading reason children die? And that is rejection. Signs and symptoms of rheumatic fever include Remember, rheumatic fever is due to a strep infection that wasn't treated properly. How do we treat rheumatic fever? Long-term antibiotics. And remember that heart valve, if it's damaged, it's damaged. It doesn't go away. So it's a little bit of everything that can happen with rheumatic fever. Again, treatment, long-term antibiotics. Multi. The child's about to have a chest tube removed. What should you do? You know, the adults told me it burns like intense burning. They always say it's almost the worst part of the surgery. So always explain. Tell them it's going to hurt. Medicate them for pain. And this child should be sitting up. The semi-failures. If you lay them down, it's going to hurt even worse. Plus, you need their airway to be expanded, their diaphragm's lower, so never supine. A child just had some surgery, can't cough, and can't cough enough to expectorate the secretions. What is your priority? What happens if they're not coughing and expectorating secretions? Abdominal surgery, chest surgery. So we know that what treatment they need to expectorate that stuff, but they're not going to do it unless you medicate them for pain and they're comfortable. Then you can have them do incentive spirometry. They can get out of bed, reposition, ambulate, all that stuff. Medicate first. Remember to medicate first. An infant of 3 months has a fever of 1036. What would you medicate the infant with? And only acetaminophen. Before that, they can't tolerate aspirin or ibuprofen. It has something to do with bleeding, right? Aspirin, prolonged bleeding. Ibuprofen, too, also has bleeding coagulopathy issues, too. A newborn infant is assessed and you find very weak lower extremities. What should she do next? So, what do you think she is suspecting? And how did I tell you you could diagnose that? What do you do? Very weak lower extremities. It's probably a coarctation of the aorta, right? So, what are you going to do? Let's check the upper and lower blood pressures. If the lowers are lower and the higher extremities, upper extremities are higher, low pulses, coarctation. A multi. A critically ill child is on complete bed rest. What can a nurse do to prevent complications? You know, we have children in a hospital long periods of time, you know, and they do, you know, get things like bed sore and, you know, problems with, you know, pulmonary complications, just like adults would. So incentive spirometry, keep them dry, use pillows, blankets, toys, all of that. Now, elevating the head of bed, it depends on the child. It's not always. I mean, it can help, but can that child have the head of the bed elevated? How can oxygen be delivered that's easiest tolerated and accurately monitored for infants? And that's your oxy hood. Very good. You remember that one. A multi. What procedure are used to keep the lungs open with a child with cystic fibrosis? And I would say aggressive. Have you ever seen those little vests up the machine and just vibrate? They use them for children and they use them for adults with cystic fibrosis. But it's chest physiotherapy, deep breathing, and again, exercising. You would not say ambulating PRN, you would say Q4 hours, QID, TID, not just whenever they want, more frequent. Multi. Children with cystic fibrosis require pancreatic enzymes with meals. What teaching should be done? You probably had an NCLEX question, very similar to this one. Take them right before the meals. You can sprinkle it on their food and rinse their mouth if you use the powder. And then the one thing I told you, make sure that as they grow, gain weight, that we do change the dose. Very good. What is the cardiac defect where there's no valve between the right atrium and the right ventricle? Remember, A means without. And what is the valve between the right atrium and the right ventricle? It's a tricuspid valve. So that A without tricuspid atresia is that no valve, okay? That's how you remember. Last question. When an infant is breathing fast, tires easily, and needs rest periods during feeding, what should you assess? What do you think is going on? Sounds like that child, that 3-month-old little girl that I got, congestive failure. Yes, listen to the lungs. What's going on with the lungs? Very good, guys. We made it through. Anna, good job, Anna. Number 2, Kimberly. Good job, Kimberly. Number 1, Libby. You said so. And Kirsten and Bree. So again, this is cardiac. It's a lot of, hard information. If you don't get it, you don't want to meet with me, I can help you some more. It's okay. You've got that handout. It has all those key things on there that you should know. So just, review those things. Remember, I said the pediatric assessment project, 3 sections. One is a paper of a 250-word APA paper. Describe what that topic is. As I said, pick something that you know or you've seen or want to know more about. You can hand that in whenever you want. The second is the form on week 8. Copy it out and you could circle it. The major points of that are the theoris and the NANDA diagnoses in the last 2 pages. So make sure, if you want to make sure it's done right, send that early. I'll tell you if you are good or not. And the third part is teach me something with that diagnosis that I need to know to take care of that child. Okay. So that is that pediatric assessment project. Remember, next week is going to be your reviews. I do mine next Thursday. So I will see you all. If you need anything, just holler. Anybody who wants to meet for that exam to find out what they got wrong, please. If you're below a 78, please make an appointment. I will not take up much time with you, okay? I know how precious your time is. Any questions?
What time